I'll assume we're recording. So I am happy to introduce Karen Stout for Grand Rounds today. Karen introduced me about 8 or 9 years ago, and I'll ignore the fact that when she did so, the only academic achievement she highlighted was the fact that it was held back in 6th grade. And when she introduced me, she said, and I quote, "Eric Krieger is a delinquent." And I'm a better person than she is, so I'll do nothing like that. Karen went to medical school at the University of Arizona and then did her medicine residency at OHSU and came to the University of Washington for cardiology fellowship, and she's been here ever since. And because Karen is very, very old, she trained in adult congenital heart disease before there was any formal training pathway to do so. She extended her cardiology fellowship at Seattle Children's Hospital under tutelage of Tom Jones and Mark Lewin, and then came here to the University of Washington, where Catherine Otto handed over an entire panel of ACHD patients to Karen and subsequently left for a month. So over the ensuing decades, Karen has grown the ACHD program into one of the largest in the country. When I joined in 2011, I was only the 2nd faculty member to join, and now we have 7 recruiting an 8th and still growing. Now, Karen has a ton of accomplishments that a lot of you are aware of, but I think at the core of them are really the establishment of ACHD as a field. As I mentioned before, Karen is old, and when she started, ACHD had this reputation of being this sort of band of quirky weirdos who used obscure eponyms and made up sounding diagnoses to make sure that no one could follow what we were doing. But because that reputation is only partially true, Karen worked very hard among a series of leaders to bring ACHD into the mainstream, or at least a mainstream adjacent field of cardiology. And she sort of entered into this alphabet soup. She helped develop the COCATS-4 criteria for training in congenital heart disease. She led the effort to make ACHD an ACGME approved pathway. She was an architect of the first ACHD board exam and subspecialty certification by the ABIM, and an author of the ABIM ACHD board examination. More recently, she has done the ACHD milestone criteria for what it means to be an ACHD specialist. And as most people know, she was the chair of the 2018 AHA-ACC guidelines for the care of adults with congenital heart disease. So, when you take all that together, Karen has really brought the field of ACHD into something that some people did, into a field of cardiology that is genuinely its own specialty, with training guidelines, certification, training standards, et cetera. And she deserves a huge amount of credit for where we are today. I'm appreciative of a number of things that Karen has done for me during my career. When I was a fellow, I did not know what I wanted to do until I looked at Karen and was like, I think I want to do that. And I've done my best to try to do something similar to that. And she's given me a ton of opportunities along the way. But I think the most important thing I've learned from her is that you build through building culture. And what Karen has shown me is that to make things work, you have to make a team that works. And when you make a team that works, you do that by showing respect and trying to support the people you work with. So, Karen, I want to thank you for sort of imbuing that into me. It took me a while to figure out, but I learned it from you, so thank you. So now Karen's going to dive back into the alphabet soup of the ABCDM and talk to us about the new set of letters that she's trying to bring along. Right.
Thank you, Eric. Thank you, Dr. Krieger. I'll limp my aging body up here. Aged. We'll talk about how everybody around me has aged me. All right, so everybody preferred my title of TBD, and I should have just stuck with that. The TBD was partly because I needed a better title. That obviously didn't happen. This remains a very boring title. And I needed to make sure that I knew what things I could share from this board and what not. So let's move forward, which it, of course, was doing and now is not. There we go. Let's go to the disclosures. I don't have any relationships of any variety that are financial or otherwise. I am on the board of the American Board of Cardiovascular Medicine, which is why I can tell you anything about this. So it does mean that I actually sort of believe in what they're doing. I will say, however, I have also been on the cardiovascular board of the American Board of Internal Medicine, and I served on its exam writing committee for ACHD for 11 years. So I'm not anti-ABM. What am I hoping you're going to take away from this talk? Well, the first one is not to become so bored that you start scrolling. The massive audience in the room, but I appreciate you all who are here, will be my bellwether for that. So the task that was set to me for this Grand Rounds was to update folks on the American Board of Cardiovascular Medicine because it's a big paradigm shifting proposal. The hindrance is there aren't any decisions that have been made yet. So I'm going to update you on the process and kind of where we're going and where we might end up. The other thing is it doesn't apply to everybody. If you're not a cardiologist, this isn't directly applicable to you. So what I'm going to try to do by reaching back into my experiences with ACHD is give some people some hints as to how this might be a relevant concept, even if you're not a cardiologist. And then at some point when I thought this was going to be maybe a 15-minute, I don't have much to say, depending on what I'm allowed to say, I queried in clinic and the Echo Lab as to what people would want to hear about. And I'm going to try to incorporate a few of those asks. So what I want you to take away, if you're a cardiologist, how might this new board affect you, whether it goes through or not? And it is still in an unknown phase. If you're not a cardiologist, just an appreciation of how board certification is more than just an exam. And that's where I'm going to really tap into the ACHD thing. And then for everybody who is looking at evolutionary fields in cardiology or elsewhere, how might the journey of ACHD kind of be a roadmap for, if you will, credibility of other disciplines? So we might have a new board. Questions arise. The first one, who cares? I have to take an exam, whatever. More pragmatically, what does it mean for me? And really importantly, will it affect my time or money in the positive? But there's a bunch of really conceptual things, which is why I got attracted to the idea of this board. What does it mean now to be a cardiologist, and how might we project forward to what being a cardiologist is? What does a cardiologist have to know to do their job well, and how do you measure that? And then beyond just the name on the certificate, what changes might come from a new board that is separate from internal medicine and is a cardiology board? So I'm going to try to tackle all of those. But I'm also going to try to tackle what I was asked to talk about by people who were going to be here. When I asked, what would you like me to talk about? Dogs, sports, socks, vacations, work-life balance, and then a few things around program building, what I might have learned from my patients over the years, and something about aging ACHD patients. So I'm going to try to make a really lovely challah and weave some of these things together. And hopefully it's not going to end up the nasty combination on the left of really awful flaming Cheetos on a bagel with cream cheese. It's going to be my new addiction, wasabi-covered almonds. God, they shouldn't be a thing, but they're amazing. And if you come to the Echo Lab, I am happy to shell those out for you. So a background on American Board of Medical Societies, which one would not want to have to know anything about, but I was sort of curious about it. So there are 24 member boards. And I highlight medical genetics and genomics because it is the last board that was newly approved by the American Board of American Board of Medical Societies in 1991. I will call out, however, and I'm going to come back to derm, OB, ophthalmology, and otolaryngology. Those, oddly enough, are the founding boards of the ABMS in the 1930s. So it ain't internal medicine, which is now its largest board. It is those four. So I'm going to come back to that eventually. And then when you look at the ABMS site, the empowering innovations, professional growth, supporting healthcare quality and safety, integrating assessment, lifelong learning, and professionalism. So those are their goals. So if you're going to be an ABMS board, you have to adhere to what they do. If you look at the American Board of Internal Medicine, with whom we are familiar, those are its subspecialties, also known as what most of us end up doing for our internal medicine training. So hepatology is the one thing that's a subspecialty of GI. The others don't specifically have a bunch of board certified subspecialties, with one exception, cardiology, which already has 4. And if you think about cardiology, as I talk about ACHD, please feel free to substitute cardio-oncology, cardio-OB, structural heart disease. 10 years ago, was there a structural heart disease program that our fellows all got siphoned into? No. It's an Everything in medicine is evolving, but cardiology is evolving particularly quickly, both in terms of the intellectual side of it and in terms of the procedural side. So that is actually a foundational basis for the ask to separate cardiology as its own board, because it has more, the argument goes, it has more in common with itself and its growing subspecialties than it does with neurocritical care. So with that premise, this was the proposal made to, you can read that, to form a board, American Board of Cardiovascular Medicine. The proposal was supported by all of the major professional organizations in cardiology: ACC, AHA, Heart Failure Society of America, Heart Rhythm Society, and SCI, which is the Interventional Society. So all of those representing their membership put this proposal forward. I am talking to you because I'm on the board of directors. This is the board of directors of the ABCVM. It is chaired by Jeff Kuvan, who's awesome. He's a general cardiologist, largely, who currently runs a pretty good-sized health system on the East Coast. Representatives on that board include imagers. Jim, you'll be happy. There's imagers on there. There's there's a fellowship director on there, but there's also interventional, EP, gen cards, and I am the ACHD person, which is okay. We're used to being the only one in the room. What are the ABMS competencies and continuing certification? Particularly fellows will see all of these because they're incorporated into your evaluations and how we do feedback. But this actually comes from the ABMS. So if you're a new board, you have to incorporate the competencies, and there are 6. And then there are components of continuing certification. Any comments I make, I'm going to really focus probably on some of the differences in the continuing certification. The initial certification, the board exam that you take after you finish your cardiology training, is not a target of change. Nobody is complaining about that. What people are concerned could evolve is the continuing certification concept. So when you look at this, we're going to kind of think about a little bit, these are the pieces of continuing certification, which do include lifelong learning and have one assessment of medical knowledge. And yet so much of what we assume is a board is that assessment of medical knowledge, because when you take your board exams, you have a high stakes, do not fail it or bad things happen, exam awaiting you. And then historically, you had that again every 10 years in order to re-up. And you re-upped in cardiology. And when I was on the cardiovascular board of the ABIM, we effected a change where the only thing you had to re-up was your terminal certification. So acknowledging all of those subspecialties. If you're an interventional cardiologist, you didn't have to redo cards, you didn't have to redo internal medicine. This is what the ABCVM's goal is: set standards and implement certification for cardiovascular clinical competence to benefit patients and the profession. The argument for this board and for the proposal is that cardiology is now its own specialty, that it has less to do with internal medicine than it does itself. And that is reflected by a multitude of departments of cardiology that are separate from internal medicine around the country, at private hospitals and in academic centers. It is not uncommon that cardiology has distinguished itself as its own thing separate from internal medicine. There is when polled, a very strong support for an independent board from cardiologists who have a variety of reasons. In some cases, it's because people really want to tell the ABIM to go pound sand. That's actually not my motivation for being involved in this board. I'm involved in this board because I think there's an opportunity to really be more innovative and more creative and more efficient in how we assess competency and how we encourage people to keep learning how to be better cardiologists. There is definitely discontent, lots of support across the profession. The intent of this board is to focus on competence as you can assess it in a multidisciplinary path. And these are the specifics that I can't lay out yet until the proposal is actually approved. Practice specific. So the idea is I'm going to touch on, if you're an ACHD cardiologist, how much do you really need to know about which catheter to put where? God knows I don't. And then having an evidence-based portfolio of what you're doing that feeds into the idea that you're maintaining your competence in what you do and meeting all 6 of the competencies set by the ABMS. So there's sort of an existential question in here. Are we cardiologists still internists? For those of you who know me, you know that I have an internist connection, namely my wife. So her clinic this week had hypertension, depression, diabetes, preventative healthcare, atrial fib, asthma, anxiety, skin lesions, STIs, yikes, it's back. Joint pain, earwax, it was specifically dried earwax, hyperlipidemia, GERD, obesity. What I did in my clinic, valve disease, heart failure, arrhythmias, edema in variety of places, cardiac surveillance, hypertension, hyperlipidemia. What I stayed really far away was the dried earwax, like no. I also, the nethers are a never in our clinic to the extent STIs not happening. Do we address depression and anxiety in the ACHD clinic? Absolutely. Upwards of 40% of patients plus who have ACHD have concomitant depression and anxiety that can really impact their quality of life. Am I the one prescribing or treating? No. Am I making sure they get to the person who's expert at that? Yes, because I'm not going to pretend to have an expertise that I don't. So there's not a lot of overlap between what my internist other half does and what I do. There's a little bit, but what she is an expert across an extraordinary breadth of things. What I am is an expert across a very narrow breadth of things. And both of those are their own specialty. And I would argue the same thing for general cardiology. It is its own specialty. I can't do what Alec Mormon does as well as what Alec Mormon does. They are different specialties. When we look at congenital heart disease, and I thank you, Eric, for both of these next slides. When you look at congenital heart disease at patients who underwent surgery, and this is really looking just a very quick, what do they die of? And if you look at more complex heart disease, the blue in this is cardiac and congenital heart disease related causes, and the orange is non-congenital heart disease related causes. So if you think about congenital heart disease, somebody who had a PDA ligated when they were a kid is not going to have a lot of consequence typically. So indeed, those patients, when they die, they tend to die of non-CHD related issues. On the other hand, if you've got a single ventricle or transposition, you're much more likely to die of issues related to your congenital heart disease. So then when you look on this, what do they die of most frequently now? It's heart failure. So heart failure is still the dominant cause of death in ACHD. And Andy is going to talk to us about this in depth next week. But the very simple thing is ACHD ain't acquired cardiovascular disease. Just throwing GDMT at a bunch of ACHD patients is actually not going to have the benefit that you'd hope. So within ACHD, I got to know a lot about their physiology, their anatomy, their age, all the things to try to manage their heart failure, which is the leading cause of death at present. So which is more important that I, as an ACHD cardiologist, not just learn, but keep up with? Is it more important that I keep up with diabetes? I promise you, I can barely spell insulin. I'm not going to be managing the diabetes, but I need to be all over heart failure and all of its nuances, even if I'm not the one taking care of acquired heart failure in the outpatient setting. There's also the inpatient setting where clearly we do that, depending on what your job is. Okay, back to the who cares question. It's just a board exam. Physicians are completely used to them. It's a rite of passage. If you can't take them, you're not here. So learn to take high stakes exams. And we just sort of, there's between a couple of my colleagues who are like, whatever, I'm used to it. It doesn't bother me that much. But it's not just a board exam. So what about the path of legitimacy to ACHD? As Eric mentioned, I've had the opportunity to participate in essentially, to some degree, everything in ACHD that has sort of added to its legitimacy, which has been able to sort of expose me to what legitimacy is. So I found that on my shelf. That's me as a fellow coming in saying, yeah, ACHD, that sounds like a thing. And wow, it distinguishes me from all the other people who don't know what it stands for. But it wasn't really a thing. But there were really wise people here and at Children's who recognized that it needed to be a thing, that it was a hole missing. So then how do we go from me as a fellow essentially making things up to the ACHD team as up there, which is not the entirety of the ACHD team. So there's a lot of ways we went there, and I don't want for 1 second to not give shout outs to all of the senior faculty who supported me helping to build the team, but the team, as Eric mentioned, builds itself. So one of my comments on team building vis-a-vis boards is if you look at each individual within the ACHD program, and I tried to make a Venn diagram, but there's too many of the circles and it turned into a hot mess. But the middle of the Venn diagram for that group of people in this context is ACHD. but every single one of them does something else unique to the program that they bring to the program. Eric's our MRI expert. Andy does heart failure. Jill does all of the nicer things and helps make sure that resilience and advanced care planning are part of our equation. And I'm calling out the three folks in the room. But Yoni has cardio OB, pulmonary hypertension, CPETs. Jason is our token pediatric cardiologist who really brings that continuity of care. And as you all know, he's a DEI god at this point, having created a Center for Indigenous Health that is funded in perpetuity and having received the MLK Award from the University of Washington. So each person has their own identity, but each person is part of a bigger team. You get into our surgeons, our electrophysiology, ablation crew, and the other heart failure docs. And now you've got what I will argue is what makes me competent to do my job, which is that I have an amazing team around me, all of whom bring their own value. And on that picture are not all physicians. And so that's super important to know that no more can you do medicine, I don't think, well, as just you with your doctor hat. We need our APPs, nurse practitioners, PAs. We need our nurses. We need our program managers. I promise you, without Jillian, ACHD does not work, and she's not a physician. So everybody has these teams, and we really need to recognize that. So how did ACHD get legitimacy? New patient population that needed expert care. Most common type of birth defect, as up there by a lot, 1% of babies. 25% will have a critical life-threatening defect. The survival now, though, is estimated 95% to age 18. So over the last 20 years, suddenly we have lots of adults. And we have lots of adults who are living a normal age span. And we have lots of adults, though, who are doing well. Many are thriving. And there's actually now more adults by a lot than kids with congenital heart disease. Think about what the Heart Center at Children's or the Heart Center at CHOP looks like. And then think about what an ACHD program looks like and how many patients we have. We exist because of the success of them and the resource investment in them. And we need to be able to do the same things in terms of resources for us. This is really old data with a dramatic increase in ACHD, but anybody who sits on Cards A as general cardiology at the University of Washington knows that ACHD is admitted at a much more frequent rate than you've seen in 5-10 years past. So ACHD, a regular heart, is not the same thing as somebody who's had a Fontan repair and only has half a heart. I like to say those are easier echoes to read because there's fewer chambers and valves to comment on, but the physiology itself is fairly complex. So here's this unique patient population that isn't the same as acquired cardiovascular disease, and that your average cardiologist trained to take care of coronary disease, heart failure in a 70-year-old, isn't necessarily going to know how to manage a 20-year-old with single ventricle physiology. On the flip side, a pediatric cardiologist faced with a 52-year-old TET who needs a valve replacement and has coronary disease and has diabetes, has all those adult things, they're not necessarily comfortable incorporating those disease states. An argument for the value of internal medicine training, by the way, in cardiology. So what did we need next? Evidence that ACHD was actually a thing that was beneficial. So here's the initial thing. First heart surgery was a PDA ligation in 1938. And this is sort of what I'm going to emphasize as exponential growth in cardiology as emblematic of ACHD. So first intracardiac congenital repair was repair of tetralogy of Fallot in 1954, but an ASD repair using an icy cold bath and stopping the heart was done in 1952 with no bypass circuit. First ACHD program at UCLA was in 1976 by a single human being who recognized that that was going to be important, and that's the way that stayed for a long time. The first set of ACHD guidelines came out in 2008. They were largely, most of the recommendations were send to an expert. So when you were the expert and you picked them up, you're like, dang, this is not helpful. And it did a lot of teaching. So we have now ACHD, it's got guidelines, and yet is it really its own specialty and does it add value? And this is one of the kind of foundational studies from Quebec, where they looked at the outcomes of ACHD patients referred to ACHD centers in Canada, where they have consolidated healthcare of a hub and spoke model. And this was they published their guidelines saying refer patients, and they looked at the referrals that came to their centers after those guidelines, which went up dramatically. And then they looked at the outcomes. And the outcomes for more complex congenital heart disease were better in ACHD centers than they were in other centers. And so this data is part of what helps drive the idea that having ACHD expertise actually makes a difference. And it would seem self-obvious that like if you're an expert in something, it should make a difference. But the reality is like if you're an interventionalist, like would anybody question that I shouldn't be putting stents in somebody's left main? No, not for a hot second, and I'm not credentialed to do so. But is ACHD or heart failure or cardio-oncology or all these more intellectual specialties, people kind of did them anyway without necessarily having a focus or a training in how to do it. So turns out that's actually valuable, but there's still not enough ACHD cardiologists. So then what has happened, and what I want to highlight here is in 2013, back to our theme of board exams, and the credentialing that comes from being board certified, does it really make much of a difference? I will say that ABIM recognizing ACHD as a subspecialty was the tipping point for ACHD's legitimacy, because everything else spins off of that. Yes, you've got guidelines, but we have guidelines for all sorts of random things. But once ABIM recognized that this is a unique separate specialty that needs to have its own training, that needs to have its own certification, then you get ACGME, who now will help bless the training programs that get you there. ACHD programs can now be accredited by a patient advocacy group. And when you get to 2018, just several years in, 40,000 babies born with CHD, and at that time there was only 11 fellowship spots nationally because it takes a while to build up that workforce. I will say that the ABIM recognizing this started in 2008. It was a 5-year process to get ABIM to recognize this. And then it was only a 1.5-year process to generate its first exam, which was given in 2015. Currently 26 ACHD fellowships, but only a 54% fill rate. So here we have this patient population that was in need of expertise. And have we actually solved the workforce? We haven't. But have we demonstrated, again, that ACHD programs combined with other high intensity cardiac care is actually beneficial? This is Eric and one of our former fellows, Vidang, who did this study, saying that if you are an ACHD patient who gets transplanted, your best outcomes are to be at a transplant center, and at an accredited ACHD program, because the pieces of an accredited ACHD program are very set out. That's what the accreditation does. It sets a guideline. So have we solved the workforce problems? Absolutely not. So right now there's about 400 board certified ACHD cardiologists. If you believe most of our data, there's at least 1.5 million ACHD patients. Mind you, there's 400,000 with cystic fibrosis. The 1.5 million is headed towards 2 million fairly quickly. There are 38,000, arguably, if we take that 40,000 number and say 95% of them survive now, they're going to turn 18. 26 ACHD fellow grads. Thank you, ACHD fellows. And that would leave 3,750 patients per cardiologist if they all went to an ACHD center. Anybody who knows how many patients you actually follow? Oh God, no. Is that not a thing? So we haven't solved the workforce problem. So you can plug in actually general cardiology, primary care. A lot of our cardiac subspecialties are really hard to get filled. Heart failure, important, but hard to draw people to. But we're seeing that with primary care as well, general internist, family medicine. So what are the barriers to kind of people pursuing ACHD? And they're not necessarily dissimilar from some of those other subspecialties. The length of training. Like many people, Andy and I were talking about this the other day. When I was a med student, I said, God, the one thing I'm not going to do is neurosurgery. That's 8 years of training. What did I end up doing? 8 years of training. So was it necessary that I do 8 years of training? Yes, in the time. Is there an opportunity to shorten that? So people are, while we're getting paid, yes, we're not getting paid what our peers who aren't in medicine are. We've got families, we've got all these things where the financial things are really important. And at the back end of all of that training, I'm reasonably certain neurosurgeons make more than I do by a fair bit. So there's not necessarily for all of these subspecialties a financial reward that makes the additional years of training sort of work out when you've got somebody else at home saying, are you kidding me? You want to do more fellowships? So there is a lot of folks who don't want to do ACHD for those reasons. And then family moving yet again, like by the time you're on your third postgraduate training program, it starts getting pretty exhausting for a bunch of folks who are in their 30s wanting to settle down, wanting to kind of figure out how their next 10 years is going to look, not how their next 2 years is going to look. So I would argue that ABIM's acknowledgement of ACHD, the board certification, was hugely impactful in taking us from being this fun little like unique unicorn to, yes, we're still festive and we have great socks, but we're now a thing. We're a formal type personhood that can be at the table, even if our socks are a bit fun, except Krieger's. His are boring, they're black. But usually, Andy's good for some good stuff. So back to the board proposal. God, I really, really, really wanted to be able to show some amazing pictures of a Seahawks win last night. So that's all I'm going to talk about. That was awful. But it's, stop it. Hush, Niners fans in the audience, and there are some. So new coach for the Seattle Seahawks. And one of the things that he's on record as saying is the principles never change, but the methods are adaptable. And I think that's foundational to this board. The principle that cardiologists need to be competent at their job to the benefit of patients and their profession is a non-negotiable principle. That you have to have a certain amount of medical knowledge and certain things you have to do in order to do that job well is non-negotiable. But the methods of being able to assess that, teach it, do it, whatever it might be, those are what's different. So what the ABCDM is aspiring to is, as you become certified, some of the changes that they can envision is just rethinking, as everybody is, training. There are medical schools now that are competency-based where you could graduate medical school in 3 years instead of 4. If you want to go back through and do for yourself, what did I do in medical school? What did I do in internal medicine? What did I do in general cardiology? And how much of that do I use now? There's always value in the experience and in the process. And I would argue that for me, I couldn't decide on cardiology until my 3rd year of medicine residency, because I liked so many different things. So there is an opportunity to be exposed and to find your way into things you wouldn't have expected. However, there is an argument to be made that there could be rethinking of what the core foundational things are to be a physician and to be a cardiologist. Certification itself, those are going to be knowledge exams. It's not that's not a primary focus. It's the continuing certification, which can be much more adaptive and really importantly, kind of focus on giving you credit for what you already do. So after initial certification, a philosophical question: do we really need high stakes exams after you finish your fellowship? So I've touched on socks, I've touched on sports, and now I'm going to touch on dogs. So dogs, as many who have them know, actually are going to be best with positive reinforcement. If you're trying to train your dog to dog, usually it's easier to have a dog train your dog to dog, but if you're trying to train your dog to dog within a human environment, then you're trying to do lots of different things. And most trainers will say punishment, high stakes, negative things, is less effective than positive reinforcements. And so humans are not that dissimilar to dogs. And I'm going to stick with dogs, partly because they're cute and fuzzy and they're awesome, and partly because I have, thank God, not had children. They would have been neurotic disasters. But I think this idea of, can we build in more positive reinforcements and lessen the negative reinforcements, is something that is perpetual across just adult education. So what are the roles? One of the things I've heard about this ABCBM is it's all about ACC and AHA, and some have argued all sorts of pieces. It actually isn't. Yes, they sponsored it. Each member of that board is an independent human being intended to have their own perspectives. So the ABCBM is a board. It is a certifying board. That's all it is. It's a certifying board. It does not dictate training. It accepts training as put forward by the ACGME, but it doesn't necessarily dictate training, but it can open the door for training. So the whole thing is certification, and how do you use initial certification and continuing certification. And then there's the House of Cardiology, which is all the subspecialties of cardiology, but it is also all 5 of the sponsoring organizations and any other organization that has an investment in cardiology. So whether that's ECHO or the Society of Cardiovascular, CT, any of those things are kind of part of the House of Cardiology. And their role is going to be to participate in the education, continuing competence activities, like really doing things that are genuinely intended to take each person with what they do and keep advancing their knowledge. And then all of that data gets submitted to a board who then says you are either certified or you are not. So the initial certification in our proposal is, yes, it's a secure timed exam. Like, this is not different. It's a board exam. You graduate from cardiology fellowship, you'll take a board exam. It's the cardiovascular continuing certification that's different, which is the assessment strategy is a formative one. It isn't a high stakes exam. So are there questions that you answer? Yes. Are there questions that you answer, get wrong, get to learn and answer again? Yeah, that sort of concept is part of this. This is the part where the specifics I can't dive into until the proposal is actually approved. So the idea of secure timed high stakes questions is not baked into the continuing certification of this. And thus it has lots of different opportunities to demonstrate that you are learning and that you're actually retaining what you learn. So it also does all the competencies. So professionalism, all those other things that are in the competencies are part of what continues your certification. So you don't have the person who nails their board exam every time, but then walks up and kicks every single person in the shin who they see in the hallway, where that professionalism piece is going to get missed, but they continue their certification. So it's not intended to be pejorative. It's not intended to be like, ooh, we snagged you on your professionalism. It's intended to say, you're competent, as defined by ABMS, in all the different things you're doing as you do them. And how do we measure those? So a philosophical question of, can we balance the need to know information common to all cardiologists versus what individuals need to know to be effective in their own jobs? And that's one of the innovative, cool things that could come out of this board, is the idea that you've got a group of, or a batch of knowledge. You got to be able to recognize a STEMI if you're a cardiologist. You got to be able to read an EKG. You got to recognize heart block. You got to know how to treat it. There's some fundamental things. But does Chris Longenecker need to know how to manage a Fontan? No. Does he need to know, yikes, Fontan, here's who I call? Yes. Does he actually need to know how to spell Fontan? Maybe, but have a concept of what it might be? Yes. So I think there is an opportunity in this system to reinforce what people actually do and allow them to grow in there. One of the things I love about working at the University of Washington is the opportunity I've had to what I call evolve in place. I never had to leave to do cool new things. I got to do cool new things here. But that also means now I've lost some knowledge I probably need to get back, but there's some things I need to know that are really different than what I needed to know 10 years ago. And how does that continuous certification work to be more efficient? And this is just my own bias. This is not baked into any proposals. But asked to touch on work-life balance, one of the things that's really awesome about work-life balance, like what does that actually mean? Does that mean that we're all doctors who go play golf on Wednesday? God, I would love that. What it actually means, in my view, is that when you're not at work, you're not at work. You're not carrying it with you. Why does everybody hate Epic and its inbox? Because it never leaves you. You are expected to deal with it, even if it's a Saturday night. So is that work-life balance? No. Is sitting down and doing a bunch of general cardiology questions on something you don't do that you're going to have to do on a weekend or night, is that necessarily work-life balance? For some people, it's fine. They love doing that. For others, it may not be. So is there an opportunity to allow people to be away from work, truly, to work reasonable hours? God, we need that for the entire profession. Is this one small potential piece of being able to say, I'm going to get credit for what I do at work as part of my job, and we're discounting all of that. And that's just sort of an efficiency. And then you can go on your vacations to wherever they might be, or go play pickleball after work and not be worrying that you're supposed to be catching up on some sort of batch of high stakes questions or studying. Everybody was so happy when they were studying for the echo boards and the cardiology boards. Like, you're not going to necessarily have to spend your weekends doing that if it's something that's a more dynamic process, which is where the innovation could come from this. Becoming certified looks the same as it does now. There's all these different pieces of being a cardiologist that are incredibly important, but there are opportunities on how do you teach people that? How do you teach people ACHD when they don't have an ACHD program? It's not that easy, but there's a lot of opportunities to be more innovative in our teaching strategies. And if, as I'll get to with one of the dominoes, if length of training is a barrier and we are no longer part of internal medicine, then there's opportunities to kind of rethink that paradigm as well. So back to ACHD. What makes me competent to take care of an ACHD patient? As Eric alluded to, we actually, Michelle Gerbitz and I actually put this in an article. Prior Blalock-Henlon procedure, Blalock-Taussig Thomas shunt, Damas K. Stansel repair, bidirectional Glenn and lateral tunnel Fontan. That actually is a patient's history. It makes no sense to everybody. For 5, maybe 10 years, it made me look like I knew what I was talking about, unless I was talking to congenital heart disease doctors, and then I was in deep. This is very similar to what I hear Richard Mib-Mab and the Mibs and Mabs and the Mibs and Mabs and what they do to cardiology, to hearts as you are training or as you're treating somebody in cardio-oncology. So is it just because I actually know what those words mean? I would say it is not. And I'm going to hark a little foray here into a couple of my patients and what I've learned from them that I think is part of what makes anybody a competent cardiologist. It's a tale of two Gregs. So each Greg has transposition of the great arteries. Each Greg was treated with a mustard repair, which is an atrial level switch, which redirects the blue blood back out to the pulmonary artery and the red blood back to the aorta, so that instead of having two in parallel circulations, you now have an in series circulation like you're supposed to, which is not what they were born with. The only way they had blood mixing was through their ductus arteriosus and their foramen ovale. The downside to this procedure, aside from the big surgical scars in the atrium, is that the right ventricle is doing the work of an LV, which is not what it's intended to do. So Greg number 1 is 35. He's asymptomatic. He's got some bradycardia at rest. Sticking monitors on him is largely terrifying because he drops his heart rate into the 30s when he's sleeping. But when he's exercising, he's fine. Greg number 2, 43. He has New York Heart Association class 3 to 4 symptoms and has an ICD for atrial and ventricular arrhythmias. ICD is obviously for ventricular arrhythmias primarily, but in this particular anatomy, atrial arrhythmias can degenerate quickly into ventricular arrhythmias. So there are some paradigms in ACHD that are different from general cardiology. We do not tolerate rhythms in ACHD. Somebody's in an atrial arrhythmia, get them out of it. So from an ACHD perspective, if you want to take away something, please make it that. Get them out of their atrial arrhythmias. So here's the echoes on Greg's 1 and 2. I'll just say that Greg 1 over here has a pretty good looking systemic RV, particularly when you look at Greg number 2. He's got a little bit of SAM, which is his subpulmonary left ventricle. It's creating an outflow tract obstruction. And Greg 2 doesn't have that. So these are very different looking echoes, corresponding, not surprisingly, to the different physical capacity of each of those patients. So this is Greg number 1. Greg number 1 rode his bike from Albuquerque to his clinic visit with me 1 year. He took 10 to 14 days. He blogged it. Along the way, he was camping. He had his bike in a trailer that he was towing, and he camped at Northern California, someplace very rural. And the family was like, sure, you can set up your tent here and be here. And then they're like, what are you doing anyway? And he's like, I'm riding to a cardiology visit. And they, of course, were like, what is that? And he explained what he had. And they're like, oh my God, our son has transposition of the great arteries. And their son is 8 years old. And so he and the son are still friends from that experience. So what do I learn from this Greg? First of all, you wouldn't necessarily know to sit there and talk to him that this dude could or would ride 1,500 miles to a clinic visit. Once you get to know him, you do. But there's also no guideline, no anything that gives me, thank God he didn't ask for permission. He just told me he was doing it. They're like, did you notice what Greg's doing? He sent us this blog, and he was like 8 days in. And we're like, oh, well, fantastic. We did stick him on a CPET, just BT dubs, as soon as he got here, which is, of course, maybe a little silly. He didn't crush it. He was like 75, 80% predictive of his CPET, even for somebody with transposition. So what did I learn from that, Greg? What I learned is that we need to create these spaces where we do the best we can to keep them healthy so they can do the things that bring them joy, bring them value, and try to risk assess the best we can. But what about the other Greg? The other Greg, if you can look at that picture up there, pulmonary hypertension with a wicked high wedge of 53, I think, on there. I had 28. He had the highest wedge ever recorded in the cath lab when he first walked in. It was 60 initially. He was medically treated, and that Greg, his picture is with his permission, has subsequently been transplanted and is doing amazing. He lives in Bend and is living his best life. So what have I learned from my patients? You never can quite predict how their outcomes are going to be, and caring for them isn't just caring for their heart. It's trying to put them in a position to live their best lives, and you can't do that by yourself. So medicine is fundamentally a team sport. And if you're going to have board continuing certification, how you interact with teams is incredibly important. And like the ACHD team, any successful sports team, you can't have everybody doing the same thing. They all have to have their own, they're wearing the same jersey. We all wear the ACHD jersey, but everybody does something different. You do have to have some overlap. If George Kittle would just please sprain his ankle, I'm kidding, I don't want illness to him. Yes, the next person up might not be as good a tight end as George Kittle. For those who are football fans, he destroyed us last night. But you at least still have a tight end. So you got to also build teams that have overlap. So how do we accomplish some of the credit for that in our board certification? So this is the program, which didn't need to be on there. That was a deleted slide. There we go. So what might be the implications of a new board to finish up here? So these are not what's in the proposal. The proposal is an initial certification and continued certification. The ABCBM certifies, but what it certifies and what it gives credit to can influence other parts, as with ACHD. ABIM certification allowed us to do the ACGME training in the way we thought was best. It allowed programs to be created in the way that we thought was best. So could we shorten training? If you are no longer part of internal medicine, do you need to do internal medicine? Now, I took a lot of value out of my 3 years of internal medicine as a chief resident. It was great. I got to decide to do cardiology and not regret that decision because I'd explored other things. Do I still bring in any knowledge? God, no, most of it's actually completely dated. If I had to take the medicine boards, I'd probably have to redo my residency. So it has evolved as much as cardiology has evolved. How much internal medicine training is needed? Jim and I had a spirited conversation about this yesterday in clinic. And I'm not saying that I have that there's an answer, but it's a question to ask. If we are not part of internal medicine, how much internal medicine is necessary to be an effective cardiologist? For the expertise it affords, or for the exposure to specialties for people who can't decide. Could that mean a department of cardiology? There are already departments of cardiology. Many of you come from places that have a department of cardiology that is separate from internal medicine. We don't. So could that happen? Yes. Think back to what I told you were the first 4 founding boards. And in alphabetical order, the first one was dermatology. So dermatology has been an independent specialty with an internal medicine precursor since the 1930s. It was made a separate department at the University of Washington a year and a half ago. So is it an obligatory thing? No. But is it a possibility? Yes, it is. So there's that allows the conceptual piece of reconsidering how we're organized. Might it fast track new subspecialties like cardio-oncology, cardio-OB, cardiac genetics, et cetera, et cetera? And is there an opportunity in doing the continued certification differently to improve work-life balance? Maybe, maybe not. I will be honest, I put that in there because I was asked to comment on work-life balance in some way, but I do think that that concept of part of work-life balance, whether it's to hang out with your family, to play pickleball, to play golf, to go snowboard, to travel to Europe, to go biking for vacation, whatever it might be, is being able to truly walk away from work. But is a new board absolutely necessary? And this is where I say, like, just the proposal may affect some changes that would be incredibly helpful. It actually isn't necessary. The American Board of Thoracic Surgery has existed since the 60s and still does. It hasn't changed at all, but their training has. Their training program changed to reflect that 5 years of general surgery wasn't time best spent to somebody who's going to be a cardiothoracic surgeon. And so they have different training pathways. And we have all of them here at UW, where they can focus on cardiothoracic surgery if they know that's what they want to do. But if they start out in general and then decide they want to do cardiothoracic surgery, they can do a fellowship afterwards. So the cardiothoracic surgery fellows here work side by side with the integrated cardiothoracic surgery residents. And the cardiothoracic surgery residency doesn't have people taking out a bunch of gallbladders, but it does have them doing vascular surgery. It has them doing cardiac critical care. It has them doing lots of things that are germane to that practice for those who know that's what they want to do. So last couple of slides, the application timeline. Where are we? They've done all the things. It is currently with the ABMS. They have ABMS asked a bunch of questions. They were answered, asked a bunch more questions. They've been answered. And so now we wait for a decision. And the decision is, at least in theory, anytime between now and early 2025. So what's the foundational principle here? We just really want people to be able to do the work they love to benefit patients and teams with their expertise and have everything else built in around it. And I love this. Do what you love and the money will follow. Ate pizza, drink wine, took a 3-hour nap. Now I wait. I would love that job, but maybe that's just work-life balance. So I think the idea of boards is just a really good opportunity, whether it comes to fruition or not, to re-envision. You kind of need those focal points in time to say, is what we're doing now the best we could do? What problems do we need to solve? Do we need to solve initial certification? No, probably not. Do cardiologists believe we need to solve a continuing certification? Oh, very much they do. Do we need to solve a workforce crisis? It's not just ACHD, it's all sorts of them. And how can we go about doing that? And there's an argument to be made, you don't solve it by shortening the back end, by shortening ACHD training, by shortening cardiology training. You solve it by shortening the front end. And there's an argument to be made for that. And these are opportunities to actually re-envision some of that, even if it doesn't come to this. So just a couple conclusion points. If you are a cardiologist, maintain your certification. Literally, if that's the only thing you walk away with today, that. Maintain your ABIM certification. This board has not been approved, and even if it is, it will honor current ABIM certifications. It cannot honor lapsed. So do the things ABIM is asking of you. If it comes to fruition, it comes to fruition, but the timeline for it being completely up and running, et cetera, is not entirely clear. But there may be opportunities to be creative and think about training opportunities. And for those of you who like to do that, ACC is doing some things, AHA, all the individual organizations are really kind of diving into how can we make sure that our membership are actually staying current and up to date. And I actually think that for anybody who's sort of looking at developing, how do we make, for example, Richard and I have talked about this a lot, how do we make cardio-oncology more legitimate, more of a thing? And I think ACHD's experience can be a little bit of a roadmap for that. And although I wanted to show Seahawks beating 49ers, that didn't happen, but that happened last night for anybody who got to see it. The Aurora Borealis was out, not quite like it was in May, but in full force. So I will end there and take any questions. Please understand everything I've put out there are philosophical things. I am not adamant about any of them because there's a lot of different opinions, but I think they're all really good questions to be asking. So thanks so much for your attention.
If you're online and have questions, please put them in the chat. If you're going to ask questions here, please use the microphones at the table. Karen, I'm going to start with the first question, which is a contrarian question.
Yeah, you? No.
So ABIM will tell you that board certification matters, and you showed data that board certification matters. You get better care from board certified people, and they've done board certification through these timed high stakes tests, and no, cardiologists don't like them. But how do you know that this softer continuing medical education, iterative focus on what you like will work to identify people who are capable of taking care of patients to high standards?
So I think that's actually exactly the conversations that are going on within the board. ABIM's data is largely around initial certifications, the value of being board certified. And they have a lot of data around that with outcomes and that sort of thing. Their data is less compelling around their previously called maintenance of certification, now called continuing certification with a pit stop past lifelong learning. They have less data to support that. So I think there's a lot of adult learning philosophies that say you don't need high stakes exams, but you do need to hold people accountable to doing the learning. So if it is, I think that's part of the philosophical question is, what does it mean to be a cardiologist? What do you have to medically know? What medical knowledge do you have to walk around with? What do you have to be able to tap into? And what do you phone a friend for? And that is part of the conversation is how do you, this can't be, if anybody remembers that board that was proposed and is actually around in a couple of places previously where all you had to do was show up for a CME meeting and you were good to go. Even I was one of the folks who was like, are you kidding me? Like, I've spoken at CME meetings. Somewhere in there, it's a powder day at Big Sky. There's surfing in Costa Rica. Like, that's why you and your family are there, and the learning is sort of a side thing. But when I've actually spoken those and I've watched the people in the room, they are there to learn. And they are there to learn in a meaningful fashion. So then how do you, one of the things that Mike McDonald, Seahawks coach, has said is like, the players are not out there wanting to screw up. Physicians don't want to, like, we're perfectionists, right? Like, we don't want to be wrong. We don't want to screw up. But a lot of people have just gotten away from the idea that a high stakes exam is the way we prove that. So I think a lot of that is creativity. There has to be accountability to actually doing it. And the idea that you can't necessarily do it on the golf course, like you actually have to sit down and go through something. But if you miss 5 questions on every 2-year high stakes exam, should you lose your certification? There's an argument against that for sure.
Great.
Karen, that was a great talk, and thank you for highlighting a University of Iowa graduate during your talk a couple of times. Just to ask, you keep mentioning a high stakes exam. I guess I'm enrolled in the thing where you have some questions that you do at home every, I don't know, it's like every quarter. I guess can you share with us, is that similar to the model, or?
The way the ABIM has structured those, and they've dialed it down each time, is that you still have to do the questions and get them right.
Right.
Period.
Yes.
Like you have to. There are ways of doing that. Hopefully not. Has anybody else done all those? This is going to be bad. I shouldn't say this. How many of the annual updates for being a physician at UW where you have to do your compliance training? There's a way of saying, fast forward.
Oh, yeah.
What are the questions? Go back, find the answers, that sort of thing. You're not trying to make it that easy to get out of it, but the idea of you missed 5 questions and now your board certification is in jeopardy is a philosophical thing they're trying to get away from. Back to the idea that this board doesn't have to exist for that to happen. ABIM and the cardiology portion of ABIM have been trying to soften that over time. So if this board doesn't go through, I think there's still the new CEO of ABIM, Furman McDonald. He's a great guy. I really like that guy a lot. There's a new opportunity for them to kind of take some of the things that cardiologists are saying and incorporate into the existing paradigm. But there still is something in there of you must take questions and get them correct. The other thing is the only CME that counts for ABIM is stuff blessed by them.
Right.
And you have to go through an entire process to have things blessed by them, and it costs money.
And then do you envision that there'll be multiple types of tests and people can choose to be ABIM certified, this one, that one? Do our trainees have to choose what, when they come out, which test to take?
So part of what ABMS is built on is the idea that it is transparent and obvious to physicians, the community, patients, and payers what board certification is. There's an argument to be made you can't have competing boards certifying the same thing. There's monopolies out there that say, anti-monopoly things that say you should be able to have that. But I don't think anybody really thinks that having 2 competing boards is actually intellectually or philosophically a great idea. Whether or not the ABIMS might say that, who knows? But
right.
Great.
Thanks, Karen. That was just a super interesting talk. Lots in there. I think, so short comment and question. Some of the frustration with the ABIM over the last several years has not been as much what they say they're trying to do, but just how they have or have failed to implement on it, with sort of decision-making going back and forth, pauses, lack of clarity. Can you, as a member of this new board, can you give us some reassurances that in addition to sort of the vision that there might be, that this is the right organization to implement on all of it? So who is responsible for selecting new members of the board? What kind of staff is available? How is it funded? Is this going to work as well as or better than ABIM in addition to sort of the philosophical and pedagogical shifts?
So the intent is absolutely that it work as well as ABIM or better. The intent is that it work better. There are, in addition to me, multiple current board members have served on various ABIM committees, exam writing committees, leadership board, that sort of thing. So they're quite, I will tell you personally, I am impressed with a lot of what ABIM does, and that would need to be duplicated by a new board. Their exam writing and how they have their psychometricians validate questions and that sort of thing. It's its own discipline, psychometricians, they're PhDs in that. So yes, there is a standard that you have to meet and then go beyond. So there are a lot of conversations about exactly how to do that, at least at a 5,000-foot level. And then we have this roadmap from the ABIM of how they've done things. And frankly, some of the other boards. what the American Board of Cardiovascular Medicine is proposing is not particularly dissimilar to other boards. Not everybody does things the way ABIM does. In fact, many of them don't. Many of them have you read articles and answer questions on articles, and that's your continuing certification. And they do it at various intervals. So there's already roadmaps with other boards. So can we have assurance? I think you can have assurance that that's exactly what this board and everybody supporting it intends to do, is that it be as good or better, mostly better than the ABIM, but it doesn't mean that it reinvents everything ABIM is doing.
All right. I think that brings us over time. So thank you all very much for attending Grand Rounds.
Thank you all.
Thank you, Karen, for an outstanding talk as always.